Okay, and the last group of lesions we're going to talk about are inflammatory periapical lesions. So basically, the periapical area of the tooth is inflamed. These are 6 or 7 things that are called cysts, but not always cysts. So let's explore them real quick. Okay, let's talk about this group of lesions for a second. So, inflammatory periapical lesions. Caries or trauma may result in inflammation, infection, chronic hyperplastic pulpitis, or necrosis of the pulp, which is death of the pulp. The inflammatory process begins in the pulp and then extends to the periapical area. Accessory canals may lead to areas of inflammation on the lateral portion of the root if there is an accessory canal available. So, these are the different ones we have. Periapical abscess. This is the most common one. Basically, purulent or pus-like exudate is surrounded by connective tissue, and it contains neutrophils and lymphocytes. Inflammation produces severe pain with periapical abscesses. So this may develop directly from the inflammation in the pulp, but it can also develop in an area of previously existing chronic inflammation. So if the tooth is hurting and there is an abscess, that means the tooth is still alive, if you can feel it. So basically, if you have an abscess and it's hurting, that means your tooth is still alive. If you have an abscess and the tooth is not hurting, that means the tooth has died. If abscesses are not treated, they can transform into greater dental infections and turn into Ludwig's angina, which we learned was a massive swelling in the tissues on the floor of the mouth and neck and can be life-threatening due to airway obstruction. So anyway, here's the periapical abscesses that you can see, the little fistula tracts. They can both drain inside the mouth and outside the mouth, as you see right here. And then you can also see the little radiolucent area at the apex of the tooth. The pus may cause a fistula to form in order to drain. The tooth can be extruded or pushed up because it wants to get away from the infection. Sometimes there can be no radiographic changes, except the first sign you'll see is slight thickening of the PDL space. And then if an abscess forms in the pre-existing area of chronic inflammation, it definitely will be seen on an x-ray as a radiolucency. How do you treat abscesses? Well, usually you have to get rid of the pus. So you need to either incise it or drain it, or perform a root canal and clean out the pulp, or extract the tooth. Okay, next one. Periapical granuloma or a dental granuloma. So, this is a localized mass of chronically inflamed granulation that forms at the opening of the pulp canal, generally at the apex of a non-vital tooth. So, periapical or dental granuloma usually is seen on a non-vital tooth. Granulation tissue due to chronic inflammation. It's associated with remnants of tooth-forming material, and it's usually asymptomatic. The bone resorbs and granulation tissue basically fills in. It may be sensitive to pressure or percussion due to sensation from the PDLs. This can come about from an abscess also that goes untreated. And then for periapical granuloma, most of the time they are discovered only by radiographs. There it is right there. Periapical granuloma. Looks like an abscess, but it is not a vital tooth. These can also cause the tooth to be extruded from the socket to get away from the infection. And then we know that the first sign of seeing it is slight thickening of the PDL. And also, same way to treat it, you want to do a root canal or you want to extract it and get it out of the mouth. Okay, then you have a radicular cyst or a periapical cyst. Now, a radicular cyst is a true epithelium-lined cyst, which we know is the true form of a cyst. However, it's associated with the root of a non-vital tooth. It develops when epithelial tissue in a periapical granuloma proliferates. This is the most common occurring cyst in the mouth. Radicular cyst, most common cyst occurring in the mouth. It's associated with remnants of tooth-formed material too, and it's also asymptomatic and can be seen on radiographs. So, what is the most common cyst in the mouth? It's a radicular cyst or a periapical cyst. There's a picture of it right there, you can see. To treat it, sometimes you have to have an apical-ectomy, which is a way to remove the infection through the gum tissue, going up and around the apex. So basically you go through the bone on the side of the apex of the tooth. You don't go directly through the apex. And so yeah, residual cyst. This is the easiest one. Residual, residing. It's a cyst that stays in the bone after the tooth is extracted. Resorption of teeth. So, this may occur when inflammation is happening. It occurs in baby teeth during exfoliation, but it also can occur with excessive occlusal or orthodontic forces, or benign or malignant tumors. We know that it occurs through ortho, and that usually is external root resorption. A reimplanted tooth will resorb sometimes. And so let's talk more about internal versus external. So external root resorption, it appears as a slight blunting of the root apex. Is external root resorption reversible? No, you cannot reverse it. And impacted teeth may resorb. So you can see in the pictures that external root resorption is the roots resorbing away due to sources that are outside that individual tooth, externally, outside. External root resorption occurs more frequently than internal. Internal root resorption. Internal root resorption happens for unknown causes. Because remember, external is happening outside of that tooth, so we know the cause. But internal, we're sometimes not sure of why they internally resorb. Sometimes it's thought to be from inflammation response in the pulp of the tooth itself. It can be seen within the crown, and if it is, it's known as the pink tooth of mummery. And this is because the enamel hard tissue resorbs away and becomes thinner, and the pink color happens from vascular inflamed connective tissue. So, internal tooth resorption in the crown is pink tooth of mummery. Now, if you have internal tooth resorption within the root, it can be seen on a radiograph, and it's different than pink tooth mummery. So how do you treat internal resorption? You have to remove the pulp. And if the tooth is perforated, it must be extracted. Here's an example. You can see in these great black and white pictures, it's a root internal resorption. The inside of the tooth is resorbing away. And then the top picture is the internal resorption of the crown, which is the pink tooth of mummery. Okay, focal sclerosing osteomyelitis. Focal sclerosing osteomyelitis. Focal means one area, sclerosing means hardening, osteo means bone, and myelitis means inflammation. So, basically, focal sclerosing osteomyelitis is one area of bone that is hardening due to inflammation. So, this is not to be confused with true osteomyelitis, which is an infection of the bone. This is different. This is changes of the bone near the apices of the teeth due to inflammation. It's thought to be a reaction from a low-grade infection. Basically, the body is noticing an infection occurring, and so it starts to create more bone. And that's why it's a hardening in one area. Typically, it happens around the mandibular first molars, sometimes premolars and second molars though. Generally, it's pain-free, you don't feel it. If it is painful, then that means it's happening within pulpal inflammatory disease. But basically, it's an overgrowth of bone in an attempt to repair itself. It's often associated with a carious or restored tooth, and it can be seen at any age, but commonly seen in young adults. So on the x-rays, it'll look like a radiopaque area because remember it's a hardening overgrowth of bone, so it's going to be thicker and show up more as a white area on the radiograph. And it can be diffuse borders or well defined. There's not usually any treatment necessary because sometimes it's not painful and it doesn't really hurt the patient. It's just an overgrowth of bone. But sometimes we want to have a biopsy just to rule out other lesions, such as osteoma, odontoma, etc. So here's a picture of it. You can see there's the focal sclerosing osteomyelitis right there, the overgrowth of bone at the apex of the tooth. Okay, last one. Alveolar osteitis, dry socket. This is post-operative complication following tooth removal. A dry socket means that the blood clot that is in the socket of the tooth that was pulled is trying to heal, and it cannot heal. It just keeps getting sucked out by the patient, by rinsing, anything like that. And when the clot is sucked out, it leaves exposed nerve endings. And so that's why it's called a dry socket. The patient can complain of pain, bad odor, and bad taste because the nerve endings are exposed. And treatment, you have to apply daily paste containing eucalyptol until the symptoms are relieved. Or you can have NSAIDs to take care of the pain. The book also talks about rinsing with chlorhexidine to help prevent these. Okay, so that concludes the part 3 of our chapter 2 section, talking about the group of lesions in the mouth.